Well, good afternoon, everyone. We are excited for you to participate in this webinar. I'm Quinn. I'm a member of the Infertility Consortium, and I am a researcher at New York University in the Department of OBGYN. We're pleased today to introduce our two speakers. Dr. Anna Koning is a medical doctor at the Netherlands Cancer Institute, currently pursuing a PhD on cancer and pregnancy with a particular focus on breast cancer. And she also coordinates the ABCIP web platform and the International and Belgian advisory boards. Joining her is Dr. Eva van Empel, who also is a fertility doctor in Utrecht, Netherlands. She joined Anna as the ABCIP coordinator. She manages the logistics and organization of case discussions, and that is the Advisory Board for Cancer, Infertility, and Pregnancy platform, and facilitates new advisory boards to further strengthen international collaborations in the field of cancer and pregnancy. So I know we have maybe one or two databases that track pregnancies of cancer or pregnancies that occur in women post-cancer and during cancer, but very interested to hear what's going on and to hear how these groups might collaborate. I will turn it over to our speakers. If you have questions, please put them in the chat, and I will read them to the speakers at that portion of the time. So thank you. So take it away, doctors.
Thank you, Gwen, for the kind introduction and the invitation. It is a pleasure to be here today to give you a glimpse behind the scenes of ABCIP, the Advisory Board on Cancer, Infertility and Pregnancy. As said, my name is Anna Koning, and together with Eva van Empel, I serve as one of the coordinators of ABCIP International. I would like to add a brief disclaimer. Although we are closely involved in the field through our work with ABCIP, we're not trained oncofertility specialists, at least not yet. Our role focuses on managing case logistics, support of the web platform, and facilitating communication between advisory boards. So today we would like to talk you through the broader picture, starting with the occurrence and the implications of cancer during pregnancy. We would like to tell you a bit more about how ABCIP was founded, walk you through the process from question to recommendation, and share some of our progress and future goals. Cancer during pregnancy remains a rare co-occurrence with an estimated incidence of 1 in 1,000 pregnancies. However, we expect this number to rise as more individuals choose to delay childbearing to a later age. Another contributing factor is the growing use of advanced diagnostics and in particular of non-invasive prenatal testing, or NIPT, which can detect maternal asymptomatic malignancies. Historically, due to the lack of long-term data for cancer treatment during pregnancy, the approach was understandably conservative. Physicians often avoided oncologic therapies out of concern for fetal safety, and this led to difficult decisions. Termination of pregnancy, early induction of labor, or for the mother, delays in treatment or compromises in oncologic care, with consequences for both maternal and fetal outcomes. That shifted in 2005 with a remarkable case at UZ Leuven. A young woman was diagnosed with cervical cancer during pregnancy, and at just 14 weeks, she was scheduled for a hysterectomy. But she was determined to continue her pregnancy. She told her doctors that it was thanks to her pregnancy that the cancer was discovered so early, and she wanted to give her baby the same chance he had given her. And together with a multidisciplinary team, they made the bold decision to proceed with chemotherapy during pregnancy instead of their hysterectomy. Something considered very experimental. Months later, she gave birth to a healthy son, and today, mother and child are doing very well. This case in 2005 has led to the formation of a dedicated task force under the umbrella of ASCO, and later in 2014 to the establishment of INCIP, the International Network of Cancer, Infertility and Pregnancy. The CIP study evolved over time to multiple sub-studies with the goal to gain insights both on the short and long-term outcomes of mother and their children. On the maternal side, we've set up registration studies, placenta analysis, psychological impact questionnaires, and even breast cancer biobank to investigate the molecular features of breast cancer in pregnancy and in the postpartum period. For the children, we look at neonatal outcomes, collect cord blood samples to investigate the genotoxic effects after exposure to chemotherapy during pregnancy, and importantly, conduct long-term follow-up on general health and neurocognitive development. The strength of the SIP study lies in its international collaboration. There are currently 79 centers in 28 countries participating in different parts of the study. In the United States, Dr. Alice Kardanic of the Cooper University Hospital in Camden, New Jersey, was actually the first to set up a registry focused on cancer in pregnancy, well before the SIP study was formally established. Today, we are pleased to collaborate with her not only on the maternal data collection, but also on the child follow-up. Today, the registry contains data on approximately 3,000 women diagnosed with cancer during or shortly after pregnancy. The distribution of cancer types largely mirrors the general incidence patterns seen in young women of reproductive age. Interestingly, we observe relatively fewer cases of skin cancer in our registry compared to what is reported in Scandinavian population data, which is then directly linked to individual health records. A likely explanation is that many cancers do not require systematic treatment, meaning that these women with skin cancers are seen less frequently in the hospital settings where our data is collected. Over the past years, several major publications have provided reassuring data on both maternal and child outcomes in the context of cancer during pregnancy. For example, studies have shown that pregnancy itself usually does not worsen maternal prognosis if you match for stage, subtype of cancer, and treatment received. We do see a delay in diagnosis, however. In terms of child outcomes, our most recent publication examined a cohort of 151 children at the age of 9 years old who were prenatally exposed to cancer and its treatment. The findings showed no significant differences in the neurocognitive development and the behavior compared to the general population of that age. This year, we expect to publish follow-up results of the 12 to 15-year-old cohort, which show similar reassuring outcomes. However, it's important to note that poor outcomes in children have been linked to prematurity and the loss of their mother during childhood. These data have contributed to a clear consensus that standard of care treatment should be followed as closely as possible during pregnancy to optimize outcomes for both mother and child. When maternal condition allows it, delivery should be ideally planned after 37 weeks of gestation to reduce the risks associated with prematurity. Nevertheless, the pregnancy does introduce unique clinical constraints. For example, chemotherapy is generally safe after the first trimester, but should be discontinued around 34 to 35 weeks to avoid maternal and fetal bone marrow suppression at the time of delivery. Radiotherapy, meaning extra-abdominal, on the other hand, is preferably administered earlier in pregnancy when the distance between the fetus and the radiation field is greatest, minimizing the fetal exposure. As for newer treatments, such as proton therapy, immunotherapy, and targeted agents, robust safety data concerning pregnancy are still lacking, and in these cases, we must rely on expert consensus, clinical experience, and case reports to guide our recommendation. That said, implementing this in clinical practice remains a significant challenge. First, due to the rarity of cancer during pregnancy, most physicians will encounter such case only once or twice in their career. As a result, there is often limited hands-on experience which can impact confidence in decision-making. Second, there are delicate situations that require careful coordination across specialties. It's not just the oncological treatment plan that matters, obstetrical considerations are equally important. For instance, growth scans is advised as chemotherapy during pregnancy has been associated with intrauterine growth restriction. And finally, access remains an issue. Not all patients live in neurotertiary centers with the necessary multidisciplinary expertise. In some cases, logistical or geographic barriers may delay timely consultations or care. And sadly, this can increase the risk of suboptimal outcomes, both from an oncological and an obstetrical perspective. Which brings us to the rationale for establishing a centralized type of advisory board. And so the members of INCIP network in the Netherlands launched a multidisciplinary platform back in 2012, known as the Advisory Group Kanker en Zwangerschap, Adviesgroep Kanker en Zwangerschap, but I will call it the SIP MDT for now. This dedicated SIP MDT was created to support Dutch physicians with clinical decision-making in challenging cases. The board included a wide variety of specialists from oncology to obstetrics to radiology and pediatricians, ensuring a comprehensive perspective. Physicians seeking advice were asked to submit an anonymous summary of the patient's obstetric and oncologic history via email, along with a standard treatment plan that would typically be offered outside of pregnancy. The SIP MDT then reviews the case and provides written recommendations on whether standard treatment can be maintained during pregnancy, and all via email. In 2022, 10 years after the establishment of this SIP MDT, the concept was evaluated. Surveys were sent out to the physicians who had previously submitted cases, and over 50% responded. The feedback revealed a high level of satisfaction with the quality and utility of the recommendations provided, and this positive reaction, combined with a clear upward trend in consultation requests, including also some from outside the Netherlands, highlights the growing need for an accessible international expertise. These insights has led to the idea of professionalizing and scaling the initiative into a digital international tumor board. And then, with the help of the European Research Council's proof of concept grants and support from Kom op tegen kanker, they were able to take it to the next step. In June 2021, ABCIP was launched, an international online advisory board. The development of the platform was made possible through the expertise of web developers at a company called Hype, while UZ Leuven, the university hospitals, provided essential support in the legal and privacy evaluation, ensuring that the platform met all necessary GDPR protection standards. The vision behind ABCIP was to create a structure of national boards that could provide localized context-specific advice, while being supported by an overarching international board to offer additional expertise when needed. Eva, I think that you will guide us through how the platform works.
Exactly. So hi, everybody. Thank you all for being here and listening to our presentation. You can hear me well, I think. Good. So now that you have a bit of an understanding of the origins of ABCIP, I'd like to present a case to illustrate how we move from a question to a written response. And here you can see the ABCIP website. So board members can log on to the website to see the forum. And if you're a physician treating a pregnant patient who has cancer or a patient who had cancer and now has a fertility-related question, you can submit your question by clicking on Ask for Advice. So healthcare professionals from around the world can submit anonymized cases and receive free advice. And we ask the physician to provide our patient with an information letter explaining the ABCIP process to ensure transparency and also patient awareness. It's important to note that the patient must be informed about the posting of their anonymous data on the website. When submitting the form, the physician can download an information letter which should be provided to the patient. So here you can see an example of a question on the website. So the cases are presented anonymously, but due to the rarity of the cases, I blurred out some of the patient-specific just in case. So the physician presents a case of a woman over 40 years old, diagnosed with triple-negative breast cancer, and she's a carrier of a germline BRCA1 mutation. She is currently being treated with an LHRH agonist and a PARP inhibitor. And on behalf of the patient, the physician asks, what is the best time to conceive? What would you recommend? Each case is then posted on a secure online platform where it is reviewed by a multidisciplinary board. And our board includes members from a wide range of disciplines, such as gynecologists, obstetricians and oncologists, but also a pharmacist and an expert in bioethics have also enriched our team by now. You have to click a little further. Yeah, perfect. On the left, you see Professor Amans. He's also here today, I see. He's the founder of ABCIP and chair of ABCIP International. And you also see Dr. Lok, who is chair of ABCIP the Netherlands. On the platform, experts can share their opinions, relevant experience, and interact with each other. And all boards together count over 200 members, of which, of course, not everybody responds to every case. And some members are part of a national board, and some are members of multiple boards. So back to the case of the woman over 40 with a history of breast cancer and a desire to conceive. Here you see some of the responses from various board members to the question, what is the best time to try to conceive? So here you see one board member responds by outlining the current standard of care, quoting, an interval of 2 years since the last chemotherapy is generally considered sufficient, as pregnancy is not recommended in the case of early recurrence. The same expert then notes the lack of specific guidance regarding PARP inhibitors and offers their expert opinion that conception may be considered 1 year after stopping olaparib. However, if earlier conception is desired due to the patient's age, it may be reasonable to wait at least 5 times the half-life of olaparib. Then 2 other board members also emphasize the patient's age and agree with the recommendations to wait at least 5 half-lives of olaparib. And another board member adds that olaparib may cause damage to the oocytes, potentially reducing the chances of spontaneous pregnancy. Then all this input is collected by the ABCIP coordinators, like Anna and I are for the international and Belgian board. And this is then compiled into a draft recommendation letter. Many cases are far from clear-cut, and in such situations we search for relevant literature, and in rare cancer types we also consult the INCIP database for similar cases. And of course we are careful not to overinterpret individual cases. Instead, we strive to provide an overview that is nuanced and transparent about what we know, and also, of course, about what we don't know. Here you can see a draft letter. We mention the absence of formal guidelines, and we share the expert recommendations, such as waiting 5 times the half-life of olaparib. And we outline some additional considerations that can be discussed with the patients, such as preconception staging to detect possible recurrence, the risks associated with delaying the RRSO, because she's also a BRCA1 carrier, and also the risks of stopping olaparib. The likelihood of achieving spontaneous pregnancy is low, so we also mentioned that. And we then advise to inform the patient about these considerations to then make an informed decision together with their physician. Board members then have approximately 24 hours to react to the concept letter. And last year we introduced a new feature on our platform, an online comment function. This allows board members to directly suggest corrections, refinements, add references, or simply endorse the draft. We think that this is an interactive step that improves the quality of our final recommendations. And then we aim out to send a final letter within 7 days, sometimes in urgent cases within 4 days. And this is what a final letter looks like, and this is what we send to the requesting physician. Then 6 months later, a short follow-up questionnaire is sent automatically to assess whether the advice was followed, what the outcomes were for the mother and her child, and what the clinician whether the clinician would consult ABCIP again. This feedback loop is incredibly valuable to us. It helps us evaluate our performance and also improve this concept. So up until now, we have a total of 96 follow-up responses. Out of the 96, responses, 74% said the advice was followed. We're very happy with that, of course. And 16% was partially followed, and only 10% did not follow the advice. And it was mostly due to patient preferences, evolving diagnostics, or unexpected clinical developments. And in 2 cases, there was a different perspective by the team, which of course also happens. Then 97% of the clinicians said they would consult ABCIP again. And many emphasize how the advice helped them feel more confident, how the fast turnaround supported their daily practice. And even some requesting physicians joined the expert board. So we're very happy with that. What does, I think Anna is taking over again.
Yes. So I wanted to share some of the progress and insights that we've gained in the past only 4 years. So let me start with briefly recap the highlights of the recent years. It all began with the proof of concept grant from the European Research Council, which enabled us to develop the platform. And in June 2021, the international Belgian and Dutch platforms went live. In 2022, a commentary was published about the ABCIP in the Lancet Oncology, and we sent out our 100th recommendation letter. 2023 was the year of expansion with 3 new national boards launched, namely Spain, Iberoamerica, ABCIP Denmark, and ABCIP Italy. And in 2024, the Dutch board published a book with patient stories and an explanation of the advisory board and workflow to celebrate their 10 years of existence. And just very recently, in January, Dr. Hemovara defended her PhD thesis, which was focused on the impact of the advisory board on the management of cancer during pregnancy. Updated until the 1st of April this year, we provided 467 cases to physicians in 48 different countries, covering a wide variety of cancer types and clinical questions. As you might expect, the clinical questions align closely with the incidence of cancer types most often seen and registered during pregnancy, with breast cancer being the most common, followed by hematological malignancies and ovarian and cervical cancers. Around 3/4 of the requests concern cancer in pregnancy, but healthcare providers are also welcome to submit questions related to fertility preservation, malignancy in medical history, or cancer in the postpartum period. And currently we have 1 overarching international board with the 5 boards I mentioned earlier, being Belgium, Netherlands, Spain, Iberoamerica, that covers multiple Spanish-speaking countries, but also Denmark and Italy. And this graph then shows the number of cases discussed by each board over time. And as you can see, all boards show a rising trend, but Netherlands has the highest volume, which makes sense as their advisory board has been active since 2012 and is well known nationally. The boards in Italy, Spain, Iberoamerica, and Denmark only launched at the end of 2023, which explains the current difference in case numbers. But what does the ABCIP future look like, Eva?
Yes, well, we always welcome new national boards. The advantages of a national board are they help lower the threshold for physicians to seek advice in their own language. This also applies to board members engaging in discussions in their own language. Of course, this is not an issue for ABCIP USA. Additionally, local contexts such as national guidelines, healthcare systems, and cultural norms play a key role in the management of these cases. So tailored advice becomes much more feasible this way. And importantly, it connects experts in this field with such a specific population, which is crucial not only for delivering the best possible care, but also for facilitating referrals and participation in local studies or registries. So looking ahead, we hope to facilitate the development of new national advisory boards in other countries. This would involve translating the platform, which again is not necessary for the USA, but It would also involve forming a local multidisciplinary team and developing visibility plans. And Anna and I are, of course, here to help with all of this. Currently, several national boards are in the process of being launched, including ABCIP UK, Poland, and Canada. And we are very excited about the potential launch of ABCIP USA. So Clarissa Bonanno from Northwell Health in New York, who I believe is also in this meeting, but I'm not sure if she is here now. Anyway, she is in the early stages of starting ABCIP USA, and any support or collaboration will be greatly appreciated for the startup of USA. Regarding the use of data for scientific research, we are working on website updates to allow retrospective research. And at present, this is not yet possible as the data is stored only for medical use and no informed consent is obtained. And in the meantime, we inform requesting physicians about the INSIP registry. We either refer them to participating centers or provide them with the necessary information to join the studies themselves. Financial sustainability is another priority. We're exploring ways to secure long-term supports or introduce reimbursement per consultation. So we're still working on that. And of course, we always welcome feedback and ideas for improvement. So we are coming at the end of our webinar. Thank you very much for your attention. If you are interested in collaborating, if you have questions or want to submit a case, feel free to reach out to us. If you're interested in joining the international board or in the future the USA board, please let us know. There are no strict requirements except for having experience working with pregnant women diagnosed with cancer or women with a history of cancer and fertility-related issues. And then a last-minute invitation. Next week on Tuesday and Wednesday, the INSIP conference will take place, and a free live stream is available. You can sign up via the website or the QR codes. So thank you very much.
Thank you. Thank both of you. Can you leave that slide up so people can access the QR code for a while?
Yeah, sure.
Okay, so I got a couple of questions that came in online. I'll go through those, and if anybody has additional ones, I think we're a small enough group and we have enough time, feel free to unmute. The first is whether or not there are any costs involved with requesting the consultation.
No, for now we don't ask reimbursement or costs. It is a free service, and we are very grateful for some support of patient organizations, but also the breast cancer campaign of Estée Lauder, for example, that can make this service available. However, we have to look for like a sustained future plan, of course, to cover the costs. Yeah, but for now
Okay.
it's free.
Thank you for that. And you may have mentioned this, but does the patient provide informed consent or permission for the clinician to make the request on her behalf?
No, we asked the physician to provide the patient an information letter stating that the physician is providing anonymous data about the patient, which is not completely anonymous, of course, in these rare cases. We asked physicians if they did that in the Dutch study, and most physicians do so, but we cannot directly have contact with the patient. So there is no signed informed consent of that sort.
Okay, thank you. The next two questions are somewhat related. So someone is asking if you also review images and make decisions, say for an example, in a cancer survivor who also has the C-section scar and worrying about the integrity of the uterus.
Yeah, thank you for these questions. I think for the first case with the images, it's quite hard because we cannot download the images on the website. It's maybe something to explore for the future. For For the second question related to the C-section scar, we can of course provide advice in those cases. Absolutely. But yeah, if we might need the images, it would be harder to do so, yeah.
Okay. And then the last question says that they think that you covered this, but they wanted to be sure that a person may request a consult with regard to the safety of someone getting pregnant or the timing after cancer treatment. Also, do you advise on the likelihood of success of continuing a pregnancy of someone who's currently on treatment or just recently diagnosed with cancer?
Yeah, absolutely. That's completely within our scope. So we had these questions in the past. As you can imagine, for instance, in breast cancer, people have a longer period of endocrine therapy, and then the question raises whether it's a good timing for her to conceive. So we can think about that in our team. Yeah, so these questions we get more often. Yeah, absolutely.
Okay. And then just my own question. So I worked with
Yeah, of
Dr.
course.
Cardonic years ago when I was primarily at a cancer center. And at one point, her registry contained information. So for people who unfortunately, had a wanted pregnancy, but cancer was diagnosed in the midst of that pregnancy.
Mhm.
And she was maintaining outcomes of the pregnancy for people who continued and did chemotherapy or radiotherapy in the second or third trimester of pregnancy. Does that type of general registry information still exist that people could say what happens to someone who has cisplatin in the second trimester of
Yeah.
pregnancy? What are the outcomes?
Yeah, actually, we work together with Dr. Koning now, and the INSIP registry. So from the INSIP conference next week, we do register those cases, and we register the oncological outcomes, the obstetric outcomes, and the follow-up of both mother and child on the long term. We cannot follow up every child, of course, but we try to motivate the patient and their family to do so, to participate in those parts of the study. So with regards to your question, we do follow the outcomes of these patients and the effects of cisplatin on the child. But we also try to register the patients that unfortunately had to terminate their pregnancy because of the cancer diagnosis, so that we can get an overview in what cases is necessary to do so.
Okay, great. That's very helpful. I welcome anyone else who has questions to unmute and ask your questions directly.
I thank you so much. This was such an amazing presentation. I'm from Northwestern in Chicago, and just had a quick question about if you've ever had sort of your experts widely disagree on a case, and sort of how do you then delineate between those two very different opinions to come up with a singular recommendation?
Yeah, that's indeed a very good question, because sometimes experts do not agree, and that is, of course, expected, as some cases are not clear cut. But we try to do is to provide every point of view in the letter. We cannot every time give like a straightforward answer, but we try to well, evaluate all the perspectives and provide the physician with some tools to make the decision themselves with the patient, of course. So to like elaborate on both standpoints. Yeah, basically.
Yeah, I think if I just can add on it, I think I want to, well, my video is muted by the organizer, so so you don't see me, but I want to confirm what Anna said, and I think we also want to not to make it is an area of many uncertainties. I mean, we have some good answers on certain questions, but sometimes we have to admit that we don't have these good data, and then actually several opinions should be equal, and maybe some person has more expertise than the other, but as Anna said, we want to reflect both visions, and we share that with the doctor who has the advice. That we say, okay, we are uncertain, we have this opinion and this opinion. We also want to respect actually the expert's opinion, and we don't make a choice therein, and we share the uncertainty with the applicant or with the physician who asks it. In some cases, but that is quite rare, that we think that is not really a good advice, and then we make a choice. But that is actually rarely. Most of the time we reflect both and share that.
Yeah. In the end, all board members are below the letter. So
Yeah.
everyone has to agree with the content of the letter, and that's very important to us.
Yeah.
Thank you. I can imagine those can be tricky situations.
Thank you for putting up the QR code and the information about the conference that's next week. Is there a website or an email address, or how do people make requests for the consultation?
Here you can see the website. If you go to app/zip.org, there's a button. It speaks for itself, and there you can upload your question, and then you will get a form with predefined questions on which we need to form advice. Yeah.
And you don't need to log in, you don't need an account, so you can just freely ask your question. So the threshold cannot be lower.
Have you had many instances of adult survivors of pediatric cancer?
Not many.
Assessed.
No.
Okay.
No.
So it's typically the requests are made on behalf of women who had the cancer sometime in adulthood.
Yeah.
I asked because I was speaking at a conference recently, two adult survivors of pediatric cancer mentioned that during their pregnancies that they were able to naturally conceive, that they had both had bone marrow transplants, or not bone marrow transplants. They both had leukemias, and they had a lot of trouble with their epidurals, that only in hindsight their oncologist said to them may have been related to the spinal taps that they had as a child for this cancer. And, wondering if anesthesiologists have particular familiarity with how to adjust or deal with epidurals for survivors of cancer. Are anesthesiologists part of your expert?
They are indeed. Yeah, we have a few anesthesiologists on board. This is of course very particular case, and I cannot answer for them. But if like a physician would ask this question, we can always ask our experts and see whether we have the provided expertise on the case. And if we don't, then we will mention it as well. Yeah.
Thank you. Any other questions?
Yes, I have a comment, Gwen. So thanks a lot, Anna and Eva, and of course, Gwen, for moderating the webinar. And thanks a lot, Professor Amand, for this great initiative. Professor Amand is a long-term collaborator to the Infertility Consortium, and we are very happy to have him on the call. I just have a question about, first of all, congratulations on the book. Your book that includes 400 cases. Is this book available for people to see or download? And is it in English or in Dutch?
Unfortunately, the book is in Dutch and it includes 39 cases. But I thought we did mention it in the presentation, as it could be a nice example for other national boards. As it is widely appreciated under the Dutch physicians and the Dutch healthcare system. Yeah. But unfortunately, it's only in Dutch. But of course, you can read the thesis of Dr. Heimovara online about the ABCIP, which he promoted on. And we have a general website, cancerinpregnancy.org. Also on the last slide, cancerinpregnancy.org, on which you can read additional studies and publications and information regarding the INSIP research.
Thank you so much.
Any other thoughts or questions? I thank our speakers very much. It's very interesting, very exciting work. Glad to see that it is universal and cutting across different countries. Expect that there'll be more great cases to share in the future. So I thank you and hope to catch you online at this conference next week.
Yeah, of course. Thank you very much for the invitation. And just to let you know, you're always welcome if you have any additional questions or if you want to submit a case to the platform.
And to join ABCIP US.
Yeah.
Yes. Thank you very much.
Bye-bye.